Good morning, ladies and gentlemen. This is the update to the hip and pelvis lecture with the inlet-outlet pelvis views included. So this is a new recorded lecture. I'll be replacing the one on YouTube, and if I've linked to that in Schoology, I'll be replacing that as well. All right, so our objectives remain the same. Again, the changes come at the end of the slide presentation, those last slides about the Taylor and Bridgman methods. So we're going to talk about pelvis and hip anatomy. The anatomy that we're trying to reveal on the radiographs for the various projections. We'll talk about the procedural considerations for pelvis and hip. Most notably, it's going to be the trousers, the belt buckles, the zippers, those types of things. Occasionally, keys and pockets. We mentioned those the other day, and loose change, things like that. So specifically, that's the big hurdle, is getting artifacts out of the waist and pelvis area. As far as patient preparation goes, if you fail to do that step, you will be repeating the radiograph. That is, if you have any, if you have an eye for quality and you have actual standards that you're practicing with. Right? We don't want to rip off the patients and give them a half-assed exam. Let's get that stuff out of the way. It only takes 5 seconds. Use of positioning aids, notably the 45-degree angle sponge is going to come in handy for those Judet views. The rest of it is just manipulating the tube and making sure you're lined up to the Bucky slot, the image receptor inside the table. Okay, most of the time you're doing pelvis and hip, it's a supine exam most of the time. So you'll throw in a cross table for trauma every now and then. Okay, and we've already done the lab for this. So, of course, future classes listening to this, you should be listening to this before we do the laboratory. All right. So starting with our anatomy, the proximal femur has notable landmarks of the femoral head. Missing from the diagram, fovea capitis, which is that little dent in the femoral head. The femoral neck, below the femoral head, where we usually find necks. The greater and lesser trochanter. Okay, lesser trochanter would be on the medial aspect of the femoral shaft, right at the top of the femoral shaft going in. So it's like the boundary line between the neck and the shaft. It's on the medial side, but it's more posterior than it is true medial. Okay. Same for the greater trochanter. The greater trochanter is slightly more posterior than it is true lateral. Okay. And so it kind of crowds the femoral neck unless we do some manipulations for the AP hip. So we're going to see that we're turning the toes in for that AP hip. Okay. In between the greater and lesser trochanter on the posterior aspect of the femur is the inner trochanteric crest, which is just a ridge or a prominence connecting the two trochanters. Right, going into our pelvis, sacroiliac joints are indicated on our diagram here. The pelvis is made out of 3 bones fused together. So sometimes they call that the pelvic bone, sometimes they call it the innominate bone. Sometimes you're referring to those 3 bones individually. So the 3 bones are ilium, ischium, and pubis. Okay, the ilium is the most superior, and the pubis and the ischium most inferior. Pubis is midline or near the middle of the body, near the mid-sagittal plane. Ischium is more lateral. Okay, all 3 bones are involved in the formation of the acetabulum. The sacrum and the coccyx are technically part of the vertebral column in the spine, but they do join and form joints with both of the hip bones. So the left hip bone is a mirror image of the right hip bone, unless pathology or trauma. Now, what's the point of the pelvis? The pelvis is basically bowl shaped, and it's to house the lower peritoneal cavity. Okay. And then also the acetabulums for lower limb attachment. Okay, so let's look at the innominate bone, the hip bone. Um, Three parts: ilium, most superior. The ilium has an iliac crest that we can palpate and an anterior superior iliac spine. It's got the auricular surface, which is the formation of, it's the articular surface with the sacrum, with the wings of the sacrum, to form the sacroiliac joint. Around the back of the sacroiliac joint, you have posterior superior iliac spine and posterior inferior iliac spine. Those are just prominences there, not really palpable below. The only palpable landmarks on the ilium is the iliac crest and the ASIS. Okay. Going down further on the lateral aspect, anterior inferior iliac spine, again not palpable. Okay. And then that's right before you get to the acetabulum. Okay. So right there in the middle, the ala also might be called like the squamous portion, which is how you call a flat sheet of bone. That's just the wing of the ilium. Okay, and then as I mentioned in positioning lab, or as I mentioned to future groups, ilium, that's part of the pelvis, is spelled with an I, so it's I-L-I-U-M. If you change that I to an E, then you get the third portion of the small bowel. So, and they sound exactly the same. So the small bowel, the word bowel has an E in it, or small intestine. The word intestine ends with an E, and so the third section of the small bowel has an E in it. Okay. The word hip and the word pelvis both have an I in them, and so the part of the hip bone is called the ilium with an I, and that's how you keep them separated. Okay. So our acetabulum, that is the it's a ball and socket joint for the hip, so the socket is called the acetabulum, and it's about 1/3 ilium, 1/3 ischium, 1/3 pubic bone. Okay. On the inside, on the true pelvis, we have the greater and lesser sciatic notch that forms the true pelvis curvature. And interrupting those curves, separating the greater and lesser sciatic notch, is the spine of the ischium. You can see it there on the inside there. And then we transition into the pubic bone, the superior ramus and the inferior ramus of the pubic bone, and then the pubic body, which forms the pubic symphysis. Okay. The superior ramus is all pubic bone. Okay, and the pubic bone extends over, the superior ramus connects to the medial inferior third of the acetabulum, which is also pubic bone. The ischium is the lateral posterior third of the acetabulum, and then it extends down into the ischial ramus, which has a bulge on it called the ischial tuberosity. Not noted here, but I'm sure we'll see it on the lateral perspective. So the superior ramus, inferior ramus, ischial ramus, they frame the obturator foramen. Okay. And that's the structures of the pelvis from the anterior, and I think we transition to a lateral, and this is where we can see the ischial tuberosity. The ischial tuberosity is, if you've ever ridden a bicycle, the ischial tuberosity is the point that makes contact with the bicycle seat. Okay, we get a better look of the ischial spine in a profile, and the greater and lesser sciatic notch, superior and inferior to that ischial spine. Okay. The acetabulum, the cup it faces mostly lateral, but it does like oblique itself slightly anterior too. Okay. There we can see the ilium, iliac crest, same parts that I went through on the previous one. This is just 90 degrees, so turn the pelvis so you're looking at it from the side, right along the mid-coronal plane. That's where your eyeballs are looking at this diagram, and then it'll make more sense to you here. Okay. So our ilium, again, um, prominences, only a couple of the prominences are palpable. That would be the anterior superior iliac spine and the iliac crest. Okay, and a common mistake when palpating and positioning pelvises and hips is confusing palpation of the iliac crest with palpation of the ASIS. Okay, the ASIS stands for anterior superior, so it's anterior. The iliac crest is actually posterior and lateral. Okay, so if you're digging and you're mashing, right, but you're on top of the patient's belly, that hard bump that you feel, that's the ASIS. You have to dig into their side, right, or closer to their spine to palpate the iliac crest. You almost have to palpate, like reach underneath the patient and palpate at their flank to palpate the iliac crest. Okay, so that's how you keep them straight and don't get confused. Palpating the ASIS is on top of the patient when they're laying supine. Okay, so as there's a hard bump, it must be no. Check your hand placement. Are you on the anterior side of the pelvis? Because the iliac crest is not on the anterior side of the pelvis. It's posterior and lateral. Okay. All right. All right. Our ischium bone. The ischium bone is inferior to the ilium and lateral and posterior to the pubic bone. Okay. It forms the posterior 2/5 of the acetabulum. The ischial ramus junctions with the inferior ramus of the pubis, but the ischium is not involved in the superior ramus at all. That's all pubic bone. Okay. The ischial tuberosity is that bulge on the outer corner of the ischial ramus, the lateral corner, lateral inferior corner, I guess. Okay. And again, if you're sitting down, the ischial tuberosity is your base of support. Okay, most notably on a bicycle seat, because that's the part that gets sore if you ride for too long. Okay, our ischial spine is just a prominence that projects into the true pelvis on either side of the bladder, I guess is a good way to picture where that is, and it separates the greater sciatic notch from the lesser sciatic notch, and that both of those form that curve that we see where that bone, that circular ring of bone coupled with the sacrum posteriorly kind of frames the bladder, and that's what we call the true pelvis, is that opening right there. All right, our pubic bone is anterior at the mid-sagittal plane mostly, but it does extend all the way to the anterior acetabulum, okay, where it fuses with the ischium and the ilium. Okay, the inferior ramus fuses with or joins with a non-movable joint. I'm not sure it's called a suture though. But there's no cartilage pad or anything. It is two bones basically knitted together. The ischial ramus is on the lateral aspect. But when you start getting medial, it becomes the pubic bone, the inferior ramus of the pubic bone. It's like basically like right immediately medial to where the tuberosity ends, is where the inferior ramus begins. Okay. Circling back around to our proximal femur, looks like we have a couple slides on this, so a little redundancy. Okay, and this is showing you picture A here on the right is close to an AP view. Yeah. So the lesser trochanter, it might be just like peeking out kind of shy. It might be all the way superimposed with the femoral shaft. Okay, and then in a lateral view in aspect B on the lower left, this is what the anatomy is going to look like for a Lowenstein method of the hip, the frog leg lateral hip. Okay, intertrochanteric crest is not on the anterior medial side, it's on the posterior lateral side. So that's mislabeled a little bit. That's more indicative of the intertrochanteric line, if that's on the front aspect of the hip. Okay. Oh, it does say it's posterior, so they flipped it around. Okay, just so they can justify labeling the intertrochanteric crest. Okay, so this is looking at like from a posterior medial oblique of the hip. Okay, like you're underneath, like you're in the middle of the ischiorami looking out at the hip laterally. Okay. All right, joints of the pelvis. There's the name of that, ligamentum capitis femoris. So that's the one that joins the fovea capitis and anchors it to the acetabulum. Okay, and that prevents hip dislocations partially. I mean, if you apply enough force, you're going to dislocate your hip. Okay, but it provides stability to the ball and socket movement of the hip. And you can see that the synovial joint space is kind of like almost like a inverted grocery bag, like a Kroger bag, wrapping around the femoral head and neck. So it goes all the way to the end of the femoral neck. It's not just around the head, and the joint space doesn't end at the acetabulum. It's actually a very large joint space. Okay. So again, ball and socket type joint, that means it's a synovial. There's got to be a double-walled membrane capsule that contains lubricating fluid called the synovial fluid. Okay. The SI joints are irregular gliding. Okay, they move. Most notably, when you frog your hip, you partially flex your SI joint and open. And then laying on your belly versus laying on your back, your SI joints kind of expand and so if you ever do a prone pelvis, you'll see that it looks like the ilia are folded inward versus expanded, folded outward. And some of that's the expanding beam, but some of that's also the gliding action of the SI joints. Okay. Pubic symphysis is a cartilaginous, slightly movable joint, but it does not have a joint space. It's literally bundles of fiber tethering the left pubic bone to the right pubic bone. All right, sorry, interrupted just a little bit. Let's keep going. Real quick, this is going to affect most notably the inlet-outlet pelvises. In particular the outlet pelvis, because we're going to use different tube angles for male and female. And again, this is biological difference. This is not social difference. Okay. Male pelvises, so if you're born with an XY chromosome, your pelvis is more vertical. It is narrower from side to side. And the bones are a little bit thicker. Okay. The angle at the pubic symphysis down here at the bottom of the diagram, in between the two inferior rami of the pubic bone, that's supposed to be an acute angle, even though that one looks like it's right at 90 degrees. Female pelvises are wider side to side, but they are not as tall as male pelvises, so they are shorter in distance so the distance from the inferior ramus to the iliac crest is a smaller distance than it is in a male pelvis, an equivalent size male pelvis. The angle of the pubic symphysis for the female pelvis is an obtuse angle. So our bony landmarks, again, iliac crest most superiorly, but again, that's posterior and lateral. Okay, ASIS, okay, pubic symphysis, and the greater trochanter. Those are the ones we can utilize. The greater trochanter is at about the level of the superior margin of the pubic symphysis. It's also just about at the same level as the femoral head. It's really close. Okay, close enough for X-ray centering. All right. So if you center to the plane of the greater trochanter for your hip projection, you're not going to be far off from what the book actually says you should center. Okay, and that's where we're going to get into localization of the hip joint without flexing. Now I know for routine hips, you just flex, look for the crease, aim for the crease, bang, you're centered to the hip. Okay, don't make things harder than they have to be. I totally get that. Okay. So the highest point of the greater trochanter lies in the same horizontal plane as the midpoint of the hip joint and the coccyx. The most prominent point of the greater trochanter is in the same plane as the pubic symphysis. So the part that when you're palpating for the greater trochanter, the part that you're going to find first, that's in the same plane as the pubic symphysis. But that's not the most superior point of the greater trochanter. Okay, so let your fingers walk up until the bump starts disappearing, and that would be a good plane to center for the hip joint. Okay. However, the book has a very specific set of instructions, and registry questions are based on these instructions here on this slide, right? So as far as answering quiz questions, memorizing these directions for localizing a hip joint, probably the most critical slide in this entire lecture, okay? So to find a hip joint without flexing the hip in the case of trauma, draw an imaginary line from the ASIS to the superior margin of the pubic symphysis. Okay, so that's a diagonal cutting across the patient's pelvis. All right. A second line perpendicular to the first one at the halfway point between the ASIS and the pubic symphysis. Okay, midpoint directly above acetabular cavity, center dome. Okay. So the midpoint of the ASI, the first line, is right at the top of the acetabulum. If you draw perpendicular along that midpoint from the first line, right, and if you proceed, some books say inferiorly, some books say laterally. It's basically along a diagonal trajectory, both inferiorly and laterally. 1.5 inches down, you'll be right on top of the femoral head. 2.5 inches down, right on top of the femoral neck. Okay? So the 1.5 inches down, that's a great place to center for a hip, right in the middle of the femoral head. And again, that'll correspond with the most superior palpable part of the greater trochanter. Okay? So you'll get partial confirmation. Okay, now if their hip is broken, their greater trochanter is going to be displaced and it's going to be tender. So you might not have the availability to palpate the greater trochanter. Okay, so just rely on the ASIS pubic symphysis line and then go about 1.5 inches lateral and inferior to the midpoint of that line, and that's a good centering point, as shown on this diagram here. Okay, so we see the topmost line is that first line that we visualize, ASIS to pubic symphysis. And then we're going to go halfway along that and drop a perpendicular heading inferiorly and laterally. Okay, about 1.5 inches down, we're right in the middle of the femoral head, even with the most superior point of the greater trochanter. Okay, so it's like you see, so we see that first line, we see the second line, those are the long ones, and then see the dotted line that says head 1.5 inches, right? That's the intersection that I'm talking about right there. That's the appropriate centering point for an AP hip, okay? And you can find that, and that's also where the crease is if they're able to bend the hip. But you have to assess, you have to look for the sign for a broken hip, right? Which was, I've told this class, but for future classes, the sign for a broken hip is the affected leg is shortened and they're not able to turn their toes in. Their toes are kicked outward or externally rotated. The entire foot externally rotated about 45 degrees. And if you ask them to turn their toes inward, they're unable to do so. Okay, so those two signs, very strong suspicion of a fractured hip, that's where you would go into this method of localization to shoot your AP hip. Okay? Because you can't manipulate, you can't figure out where the crease is because you can't bend and flex the hip. Okay? That's why it's so critical that you know this method, because there's going to be trauma circumstances where it's not appropriate to manipulate the hip. All right. So that's basically the end of the anatomy. So going into preparing for exam, patient preparation, position, I already told you supine on the exam table typically. In the case of trauma, you're going to leave them on the stretcher or the gurney or whatever it is when they're in the ED, because I assume patient got a broken hip, that's where they need to go, is the emergency room. Okay, it is emergent. Okay. IR collimated field sizes. For our pelvis views, 14 by 17 crosswise. For most of those, that would be our Judet views, our AP pelvis, and our inlet-outlet pelvis views. For the hip, just a unilateral hip, you'll be able to shoot those with a 10 by 12 vertically oriented, or what we would call portrait size. Okay. Yes, I know you don't get a 10 by 12 detector anymore, but you can collimate down to a 10 by 12 field on your digital detector, and that's plenty of room to capture the energy. So long as you center correctly, plenty of room to capture the pertinent anatomy on a 10 by 12 field. All right, SID is 40 inches for all of these. ID markers, of course, we're going to mark, there's a difference between a left and a right hip, so we're going to mark those appropriately. Pelvis, you can mark either side. Bottom corner, bottom outside corner, so inferior lateral corner, basically for all the projections, is going to be an appropriate location for an ID marker, okay, for your radiopaque marker. Radiation protection. Unfortunately, about half the population, the ovaries are right in the middle of the pelvis, right on top of the sacroiliac joint, so it's not appropriate to shield for female patients. A contact shield can be used for male patients, depending upon protocol. Just check and see, okay? Further patient's instructions, they do have to disrobe from the waist down. That's the best instructions. Put on a gown, cover them up, make sure you tell them to keep their underwear on. There are people who share way too much, if you know what I mean. So make sure you specifically instruct them to keep their underwear on. And let's see, what else? Cover them up with a flat sheet just for extra privacy. That's just courteous. Okay. All right, so we go into, and I think this is a male patient with a contact shield. Okay. Undergarments. The elastic does produce an artifact, but too bad, so sad. Right. Just be mindful that it does. I don't think your radiologist is going to fuss about it. Definitely the way we hold pants up, we haven't improved upon that technology a great deal. Watch out for sweatpants, because some of the more expensive brands do have those metal eyelets for the drawstrings, and those will show up and obscure anatomy, so watch out for those. If it's just elastic waistband, I mean, it really depends on how fussy your radiologist is. I mean, playing it safe, take off everything from the waist down, leave your underwear on. That's the best instructions, okay? Of course, provide a gown to preserve privacy and cover the patient up with a flat sheet, okay? Ambulatory patients, supine on the x-ray table. Non-ambulatory patients, use proper transfer techniques. And remember that if the hip is broken, that's going to be, the landing is going to be uncomfortable for your patient. So make that landing as easy as you can. Friction-free slide board is probably going to be your best option if you do decide to move them over to the exam table. With improvements in digital technology, you can get equivalent. Back in screen film times, you couldn't get a good quality study with a portable machine. You would get much better images in a radiographic table. But now in the digital age, the digital portable machine can produce equivalent quality images. So a lot of times the transfer is not necessary. All right, back to it. Sorry, interrupted again. Moving on. All right, so our collimated field size. Oh, look, textbook give guidelines. Well, I guess that's a nice trick to actually get you to open your textbook. Like I said, if you're imaging the whole pelvis, you need a 14 by 17 crosswise field of view. If you're imaging just one hip, you need a 10 by 12 portrait field of view. Okay. If you're doing trauma, you might want to open up a little bit bigger, and then also, again, in the digital age, sorry, interrupted again. Digital radiography in the mobile setting is equivalent quality now. So a lot of times the transfer is unnecessary for especially in a trauma situation. You can easily do a trauma hip series in the stretcher, and sometimes it's easier because the stretcher's on wheels, whereas the exam table is not. And so you get a little bit more movability trying to set up that cross table. Very handy for the patient's exam table to roll and pivot through the room into a diagonal, let's say. And then, of course, your x-ray tube also on wheels. It's just a lot more convenient to set up those cross table shots portably, and they can be done portably with equivalent quality. All right, SID 40 inches. I don't think we're going to deviate from that. Even the cross table projections, we still get pretty good body part to image receptor contact or proximity. And so remember, the strategy to increase SID ever to 72 or something like that is to compensate for OID that we can't correct. And we'll see that next week in the C-spine. When we do our lateral C-spines, again, we're going to invoke a 72-inch SID because it's just rude to lop the patient's shoulder off so that we can get the cervical spine right up against the image receptor. It's problematic. So, but for the pelvis and the hip, most of these projections, you're not, even in the case of fracture, you're not going to have trouble getting them with close to zero OID to the image receptor. Okay. So 40 inches is perfectly fine for all of these. Right, ID markers, again, at a minimum, ID markers keep your orthopedic surgeon from getting confused, keep your radiologist from getting confused. And of course, when you send them to PACS, you should be checking demographic information before you hit send. Okay. Avoid using digital annotation to place side markers on images. The legal standard is a radiopaque marker at the time of the exposure. Radiation protection. Male patients can be shielded with a contact shield, okay? Because the reproductive organs of the male are outside of the bony pelvis. For females, reproductive organs are right in front of the sacroiliac joints, approximately, okay? And so you don't have the ability to shield your female patients for pelvis and hip exams. Okay? The contact shields, as is shown in this picture, is available for your male patients. Check with your facility protocols. Other methods of radiation protection only use the amount of collimation, that is the amount of x-ray beam that you need. Okay? For the pelvis, you open to 14 inches by 17 inches. For a single hip, you do not open to 14 inches by 17 inches unless the patient has a hip replacement, a prosthetic. And so we're assessing that on the front end. Have you ever had any surgery on your hip? Right? If there's suspicion of hardware in there, then you would open up your hip radiograph to a larger field. At least I recommend halfway down the femur. If they have a femur nail, you're out of luck. Every hip exam is a femur exam. So congratulations. But if they just have an artificial hip, sometimes the prosthetic ends about the mid shaft. And so if they say yes, prosthesis, open your collimation to about the mid shaft of the femur. So open up a little bit more on individual hip x-rays for confirmation of prosthetic device. Patient instructions. Your patient's got to hold still. They got to hold their breath. Breath motion is going to move the peritoneal cavity, which is also going to move the hip joint. Okay. And I do have a represented example when we get to image critique. I think we did that for this class. We did that just yesterday. Patient was breathing through a frog leg hip exposure, and we did see a motion blur artifact on that on the PACS. Okay, so holding the breath prevents that diaphragmatic motion from carrying through the lower peritoneal cavity. Now there is going to be peristaltic motion occasionally, but usually the exposures are fast enough that you don't really get aggressive peristaltic motion in your hip and pelvis radiographs. That's more for small bowel follow-throughs and barium minimas, where you still see peristaltic motion because the exposures take too long. The exposure times take too long. So pelvis and hip radiography, it should be that, especially if you're using AECs for your techniques, automatic exposure control, you should have rapid exposure times. Fractions of a second, and so that'll help to eliminate motion as well. Okay, if you have pediatric patients, you can't use AECs, so when dialing up a manual technique on a pediatric pelvis or hip, make sure you're going increase your MA station to something radical like 400 or 500, and that'll allow you to dial up the smallest exposure time possible to try to prevent motion. Remember from your physics class, the velocity formula is dependent upon time. It's in the denominator. So if time doesn't pass, motion doesn't make sense. So that's why we want short exposure times. All right, so your position for your AP pelvis and your proximal femora, that is basically the stuff around the hip joint, down to the lesser trochanter. Okay. Your default position, your standard protocol view for an AP for a pelvis is the AP projection. So to set the patient up, lay them down on the exam table, mid-sagittal plane, centered to the image receptor, to the middle of the image receptor. And then where do we center the image receptor? We want to make sure the top of the image receptor is above, about an inch above the iliac crest, bottom of the image receptor about an inch and a half below where we palpate the greater trochanter. Okay, remember the greater trochanter is in the same transverse plane as the pubic symphysis. We need the pubic symphysis, but we also need the inferior initial rami. So we do need to go down 1.5 inches, 2 inches below the level of the greater trochanter. Okay. To make sure the pelvis isn't rotated, people will have good hips and bad hips, especially as they get older. And so when you tell them to lay down, but you're not specific about it, they are going to lean to the good hip, the one that feels more comfortable to lay on. Okay, so you will have to square them up. Okay, and a good quick check of that is the ASIS on the left is about the same distance down to the table as the ASIS is on the right. So if you palpate for both of them, and then you notice one of your thumbs is higher up off the table than the other one, that means your pelvis is rotated. You should fix that before you proceed with the projection. Okay. To get the femoral necks in profile and prevent foreshortening and overlap with the greater trochanters, you're going to want to rotate the patient's feet in 15 to 20 degrees to size up. Now it does say at that last bullet point there, don't do this if it's a trauma, okay? So if it's status post fall, status post MVA, or anything where it's acute trauma is in the history, you really ignore the directions about manipulating the feet, okay? So it's only for your routine pelvis x-ray do you make them stand pigeon-toed, basically. Tip the toes in toward each other, kick the heels out to the side. Okay, it doesn't have to be a true 45-degree angle, just ever so slightly the toes canted in 15 to 20 degrees, and that will put the hips into a true AP orientation. Okay. All right, so again, where's the cassette? 1 to 1.5 inches superior to the iliac crest. That ensures that you get the top of the pelvis on there. Central ray directed, so they recommend detent. Center your X-ray tube to your image receptor and then align your image receptor to your body part, but don't shift the position of the bucky tray. Use the floating tabletop. Okay, and so obviously in a trauma situation, you're going to be like getting the image receptor physically under the patient, hopefully using like a flat sheet in between the flat sheet and the stretcher mattress. And you're just going to have to shimmy and then kind of poke, right? Poke for the iliac crest and then knife down from that point. With your fingers, do you feel the image receptor underneath your fingers when you're knifing straight down at the level of the iliac crest? Okay, I think I taught that to this group when I talked about a trauma flat plate chest X-ray, the knifing down technique. Hey, I got this corner of the cassette is outside the right shoulder. This corner of the cassette is outside the left shoulder. This corner of the cassette is at the level of the diaphragm, outside the rib cage. Knife down on the other side, outside the left rib cage. So all the corners are outside the chest cavity. Therefore, I've got the entire chest cavity on my image receptor plate. You can do the same thing in a trauma pelvis situation. Just knife down and palpate the cassette too while you're and compare it to where you're palpating the iliac crest. Okay. So set your central ray perpendicular to the IR. When you're in a trauma situation, that some of those stretchers, the newer ones no, but some of those stretchers, they will have a dip in the middle where the foam is just worn out from so many patients residing in the stretcher for so long. Hospital beds are notorious for having a dip in the middle. And so if you're using a gridded cassette in a trauma situation, make sure the grid is horizontal at the time you shoot, or you should cant your X-ray to make sure that your X-ray beam is intersecting your grid at a perpendicular. So if you get it under there, but the grid is kind of slanted and not in a true horizontal plane, you'll end up with grid cutoff unless your X-ray beam is also slanted to match, so it's intersecting your image receptor at a true perpendicular. Okay, that's just a little veteran tip for you. You'll see it when you try to do a trauma hip and pelvis portably in the stretcher. You'll see exactly what I'm talking about. Okay. Again, your collimated field for an AP pelvis, regardless of whether it's trauma or routine on an exam table, 14 by 17 inches. Okay. Essential projection for the femoral necks. Now, typically when they order a modified cleaves, which is a AP, and it's usually in a series, AP pelvis with frog leg pelvis, what they mean is a modified cleaves, a bilateral frog leg pelvis. Okay, it says femoral necks. However, they want when the radiologist is put modified cleaves on the protocol book, they want the whole pelvis. They just want you to frog the femurs rather than try to get them in true AP. Okay, so position them just like you're doing a regular pelvis, right? But then you have to have them draw their knees up, bring the bottoms of their feet together, touching in between their legs, and then let their legs fall out to the sides. Let their knees relax and fall out to the sides. Okay. And as I mentioned in positioning lab, and I mention this every year, we avoid the use of the term spread. Okay, because it has a connotation that's going to make an awkward situation at its best. Okay, so bring your feet together, flex your knees, let your knees fall out to the sides is a great way to phrase that for each and every patient, and there's no awkwardness. Okay, so again, where are we centering to? We're centering to the cassette in the bucky tray or the cassette underneath the patient on the stretcher. Okay, and so we're making sure that that cassette is square to the patient's pelvis. So it's the same lineup as the same directions we just walked through, 1.5 inches above the iliac crest. but also check to make sure that the greater trochanter, the light extends beyond the greater trochanter to make sure we're not clipping the inferior rami of the pelvis. Okay, and we should get like the proximal third of the hip and the femur on this, not the hip, the proximal third of the femur on this. Okay, draw feet up as much as possible, that is back toward the pelvis. Good luck with your geriatric patients. You'll be lucky to put them in this position. Luckily, modified cleaves, bilateral frog leg hips are usually associated with a pediatric evaluation of a congenital hip dysplasia anomaly, okay, or pathology. And so you see this at children's hospitals quite a bit. They'll do a AP and bilateral frog series of modified cleaves for the second projection, and that's to evaluate for congenital hip dysplasia. Okay, the amount that each femur frogs, it should be symmetric. Okay, to get, just because if they frog better with the left than the right, then that's going to end up obliquing the pelvis. And so you should have symmetric level of relaxation. Okay. And how much do they let their knees down? As much as they can comfortably tolerate, basically, is the answer to that. Okay. The modified cleaves, they say center 1 inch superior to the pubic symphysis. Okay, but I'm telling you, in my experience in clinical practice, they want to see the entire pelvis with this thing. So, yes, the hip joint, it's an evaluation of hip dysplasia. So the hip joint is basically the pertinent anatomy. They're evaluating it and for its integrity. So the lower half of the pelvis, it's not repeatable if you clip the iliac crest, but I mean, they want it on there, right? So it is repeatable if you clip any of the inferior side of the pelvis. Okay, so when in doubt, center a little bit lower than a little bit, rather than a little bit higher with the modified cleaves. Okay. For a unilateral ASIS to the midline, it says to the grid image receptor, your ASIS is going to be at the middle of the top of the image receptor. You're going to switch to a 10 by 12 field for a unilateral modified cleaves. Affected hip and knee, abduct the thigh to a 45-degree angle. Okay, so this is what techs are typically doing when they're doing a frog. Even though I'm teaching you Lowenstein and Hickey, which are the proper frog methods, typically what we're doing in clinical practice is a unilateral modified cleaves with a 45-degree flexion of the hip joint. Okay, direct your central ray perpendicular to the femoral neck. If the patient is able to frog, then you should be able to detect the crease that marks the hip joint. Okay. Typically, as far as the vertical plane is going to be, it's going to be right along the ASIS. So draw a line down vertically from the ASIS, and that's where the vertical targeting line is going to be. The other targeting line about the level of the greater trochanter, and that'll get you there. That'll get you to a good center for this. Okay. For a routine hip series, I know what you see in clinical practice is more like a unilateral cleaves. The proper frog leg hips are called the Lowenstein and Hickey methods. But good luck finding a patient that's actually this flexible. It requires that the femur is put into a transverse plane for both of those. Okay. If you're unable to frog the hip due to trauma, the recommended projection is the axiolateral. The text will call it the cross table lateral. The book refers to it as the Danielius-Miller or Danielius. I don't know how to pronounce that gentleman's name. I'm sorry. Danielius-Miller method. Okay. All right. So our AP hip, center at the femoral head. Rotate just like we did for the AP pelvis. You're going to internally rotate your hip 15 to 20 degrees. Okay, that's going to place the femoral neck parallel to the image receptor and bring the greater trochanter out laterally in profile. Okay, Again, make sure your pelvis is square. We still don't want obliquity or rotation of the pelvis. So just like we checked the distance of the AS, just put your thumbs, palpate both ASISs, and make sure your thumbs are the same distance from the table. Okay. If they're not, the patient needs adjustment, needs to get squared up. Okay. Centering to the femoral neck. Use, in the case of trauma, use that localization method. The diagonal line from the ASIS to the pubic symphysis, 1.5 inches along a perpendicular to that line. At the midpoint of that line, that's the location, that's the center of the femoral head. Okay. For routine, and you got good mobility, the patient is exhibiting good mobility in that hip, then you can have them flex briefly, identify where the crease is, and center to the crease, basically. And that's the hip joint, always. Okay, so you'll see the text do that. Okay, collimated field 10 by 12 unless they have prosthetic. So asking about if they have a replacement hip, that's going to cause you to open your collimation for greater than 10 by 12 inches for a unilateral hip. Marker placement is going to be, again, inferiorly and laterally. Okay. Pause right here. All right, moving into the Lowenstein, contraindicated if fracture pathology is suspected. They should have said that for the cleaves too, unilateral cleaves. Okay. All right, rotate the patient slightly toward the affected side. So that means you can oblique the pelvis. Okay. So center the affected hip to the midline of the grid. If you just got done shooting your AP hip, you don't have to move the bucky or the x-ray tube. You don't have to move the patient at all. Just have them lean a little bit toward the affected hip and then flex the knee and let it fall out to the side. Okay. You do want to draw, this is like a little bit more aggressive than a modified cleaves. You want to draw the femur up so it's in a transverse plane, effectively. That would be ideal for a Lowenstein and a Hickey method. So you want the femur pointing laterally off the table. Okay. Lay the knee down. Okay. So how much do you oblique the pelvis? Enough so that the lateral aspect of their thigh is laying against the table. Okay. You can use an angle sponge to support the opposite hip and pelvis. That might help you with stability of position. Okay. Direct your central ray again through the hip. If you just shot the AP hip on a 10 by 12, you're already at the centering point. Okay. You just have to frog and shift a little bit. You might have to, if they oblique towards you and frog, the pelvis might shift away from you, the hip might shift away from you about 1 inch. So you might have to open the floating tabletop and draw them towards you about 1 inch to reacquire center. But it's usually a very subtle adjustment. It's not a radical adjustment. Okay. The central ray is entering halfway between the ASIS and the pubic symphysis. You'll be right on the femoral head at that point. Okay. Again, collimated field 10 by 12 is fine as long as they don't have a prosthetic. If they have a prosthetic, the ability of them to put their femur in a transverse plane is going to be compromised. They might not have that range of motion. Just understand that. Okay. All right, so if we're doing a Hickey method is the same positioning as a Lowenstein. We're just going to put on a 20-degree cephalad angle. And what that's going to do is so in the Lowenstein, the greater trochanter is going to be superimposed on the femoral neck. If we put a 20-degree angle on the projection, though, 20-degree cephalad, it's going to separate that superimposition, and the femoral neck is going to shift superiorly to the greater trochanter. Okay. And so that's the advantage of the Hickey method. And you can see comparison pictures in your textbook that show you those differences. Okay. Moving on to our cross table lateral, our Danielus-Miller view. Okay. So the affected leg, we suspect it's fractured. Okay. If the patient is asthenic or hyposthenic, you're going to have to build them up on folded sheets, build them up off the table surface. Okay. You are going to direct your X-ray tube horizontally with a horizontal X-ray beam, but you're going to, if it's on a crane, the tube angle is going to be the pivot button. So pivot, okay, pivot the tube so you end up with a 40 to 45 degree cephalid angle, okay? The unaffected leg has to be drawn up out of the way. So you have to have them raise the unaffected leg. So the left leg is fractured. We can't move it. We have to move the right leg out of the way and shoot a cross table projection of their hip, okay, instead of a frog, okay? The cassette is placed with the top of the cassette above the iliac crest, okay? I always used a 14 by 17 because I was just paranoid. I didn't think the 10 by 12 was big enough. Okay. I think the book says the 10 by 12 is big enough. In the modern age, that's a rub because you're using a digital detector that's like 18 by 18. So it really doesn't matter. Place the top of the image receptor above the iliac crest. Cant the image receptor away from the midline of the patient at about a 45 degree angle. Okay. Notice that the central ray is going to intersect this image receptor at a perpendicular. Okay. Don't let them oblique the pelvis, so check for the ASIS being equidistant from the table surface. If you can, internally rotate the leg, but if you suspect it's fracture, ignore the rotation of the leg. Okay, shoot it as it lies. All right. So I always think it's kind of silly to include manipulation of the leg instructions on a cross table. The whole reason you're doing a cross table hip is because you suspect it's fractured. Okay. You need to flex the unaffected leg 90 degrees and rest the foot and heel of the patient on a support type device. Okay. It's got to be like a foam sponge. All right. If you don't have a foam sponge that tall, you can invert a trash can, one of the circular squat ones, and put a pillow on top of it for padding. Take the garbage can liner out of the trash can before you invert it. I speak from experience. Okay. Don't let them rest their foot on an uncovered trash can. Okay. But if your facility is serious about being a radiography department, it should have a positioning sponge that you can rest their foot and heel on. Okay. Do not rest their foot and heel on the X-ray tube. That's a big no-no. There's high voltage cables coming out of that thing. Don't do that. Okay. So yeah, the unaffected leg is the one that's raised. You guys remember that for your practical, because you'll draw this and you'll fail your practical because you raised the affected leg. You're raising the unaffected leg. You're aiming at the affected leg, which is remaining horizontal, okay, and non-manipulated, okay? The patient can hold the image receptor in most cases. If they're unable to do so because they're unconscious, then someone is going to have to hold this image receptor in real clinical practice. Okay. Collimated field, collimate to the skin surface of the affected leg. You don't have to go vertical, so your vertical collimation doesn't have to go above the anterior skin surface of that femur. Okay. Central ray is going to intersect the femoral neck. Okay. Yeah, it's going to be, you're going to aim right at their business. Okay, that's how you, if you look at the last picture closely, that's where the central ray is basically directed, right in the middle of their groin. Okay. Clemens Nakayama, I'm required to teach this to you. I've never shot one. I've never seen anyone shot one. When would you utilize a Clemens Nakayama? When they've broken both hips. Okay, so you can't move the unaffected leg. You can't manipulate the unaffected leg. There is no unaffected leg. So if you're in a situation you're doing a Clemens Nakayama, you're going to do both of them. You're going to do a Clemens Nakayama for the left broken hip and the right broken hip. Instead of moving the leg out of the way, if we can't manipulate the body part, we have to use a compensating tube angle. So not only are you going 45 degrees to the head or cephalid instead of a true cross table transverse plane central ray, still 45 degrees toward the head with a pivot button, but then you're going to use the tube angle button to direct the central ray 15 degrees toward the patient's posterior, or toward the floor is a better way to say that. Okay, so you don't get confused. The cassette, this is where a 10 by 12 is more helpful. Unfortunately, you're stuck with a DR plate that's 18 by 18. You do have to roll the patient up slightly so you can partially tuck the cassette under them like you're doing a posterior oblique projection. Okay? It says unaffected leg not moved, but it also, in the very next bullet, says image receptor tilted from the vertical 15 degrees. Yeah, you really do try to tuck it underneath partially. Okay? It's important that the plane of the image receptor is canted backwards 15 degrees because you want to maintain the perpendicular relationship with the central ray. Judet views. Posterior obliques of the pelvis, 45 degree angles. Okay. Unilateral, center for either the downside or the upside acetabulum, depending upon if you're doing the external Judet or the internal Judet. I've done a Judet view exactly once, and I did not do it unilateral because if you look closely at these diagrams, see how the right hip, when it's the side elevated, that's considered the internal rotation Judet view. So in picture A. But if you look closely, the left acetabulum is in an external rotation. Compare the left acetabulum in picture A to the right acetabulum in picture B. They're a mirror image of each other. They're in the same position. So the downside hip is always in an external rotation. The elevated side hip is always in an internal rotation. Okay. Now it might be that they're just having problems with one of their hips. And so you could get a unilateral Judet view series, but I've never seen a radiologist. I only shot it once. It was at Vanderbilt, and it was a bilateral. And so, yes, the book describes the setup for a unilateral with a 10 by 12 field. I'm telling you, in clinical practice, you can save radiation and only do 2 exposures instead of 4 if you just use a 14 by 17 crosswise and get both the internally rotated elevated side and externally rotated non-elevated side in the same exposure field. And so you'll modify your centering directions. You should probably center straight at if you're doing bilateral, center straight at the pubic symphysis. If you're doing unilateral, center right at the femoral head. Okay. Internal oblique demonstrates the posterior rim of the acetabulum and the iliopubic column. So that's on the true pelvis. The true pelvic border between the ilium and the pubis kind of sets itself up in profile really well on the internal oblique. On the external oblique, you're going to see the anterior rim of the acetabulum and the ilioischial column, which is kind of like the posterior posterior edge of the true pelvis. All right, so why do they call them Judet views? Well, that's so they can fool the less educated, the ones that take less effort to achieve maximum comprehension. It's up to you to remember that Judet views are just 45-degree obliques of the pelvis. They're not going to say, on the 45-degree oblique of the pelvis for acetabulum, how much do you rotate the patient? Well, they just kind of gave away the answer, didn't they? But if they say, on the Judet view of the pelvis, how much do you rotate the patient? And you've forgotten what the word Judet view really means, then they got you. You see? So referring to them as Judet views gives them an opportunity to ask a comprehension question on the registry exam. Yes, they are that petty. They absolutely are. So that's why you have to learn Judet views means 45-degree posterior obliques of the pelvis, because it's too simple to tell you AP oblique, RPO, LPO. It's too simple to say that. We can't generate a quiz question if we do that. All right, so as far as centering, remember these centering instructions are 2 inches inferior to the ASIS on the affected side. So that's a unilateral centering instruction, okay? I would go 2 inches inferior to where both ASISs are, right? At the mid-sagittal plane if I was doing bilateral Judets, which again, I'm pretty sure that's the way you're going to want to do them, okay? Because usually when you're doing Judet views, it's comparison views. There's a pathologic hip and a non-pathologic hip, and they want a comparison interpretation. Okay, for our external oblique, again, that's centering to the affected side down. Internal oblique is affected side up. Again, these are centering instructions for unilateral evaluations. Okay, so 2 inches, again, 2 inches inferior to the ASIS at the mid-sagittal plane is probably better instructions. Okay, for bilateral. Okay, and this is where we get to the new content. This content that wasn't present on last year's lecture. Okay, so this is inlet and outlet pelvises. Typically, you only see inlet-outlet pelvises with C-arm in surgical repair of a fractured pelvis in a level 1 trauma center. Okay, that's the only place I've ever heard of it being utilized. Okay, so the Taylor method is the outlet method. Okay, you center to a point 2 inches inferior to the pubic symphysis, but it's an aggressive cephalad angle. For men, 20 to 25 degrees. For women, 30 to 45 degrees. So what you're trying to do is the rami, in particular the inferior initial rami, they're kind of obliqued backwards from the anterior to the posterior. If you go back and look at the lateral view of the pelvis, you'll see what I'm talking about. You're trying to present the rami in a true AP projection with an outlet pelvis. Okay, and so you want to position them like you're positioning for an AP pelvis. Make sure the as-is to tabletop distance is equidistant for both the left and right ASIS. So square the pelvis up. Don't let them list to one side or the other. Okay. It says flex the knees slightly. That's just to make them, I think that reduces lower back strain, makes them a little bit more comfortable. The reason there's 2 different angles to memorize is because of the differences in the anatomy of the biologic male pelvis to the biologic female pelvis. Okay. So again, 20 to 25 degrees cephalad for the men, 30 to 45 degrees cephalad for the women. Okay. No one's going to call this the Taylor method in clinical practice. They're going to say inlet-outlet views. And so if you're doing this one, that should give you a big clue that you're also going to do the Bridgman method, which is the inlet view. Which I think this one is good evaluation of the integrity of the rami. If you suspect some kind of injury to the pelvic rami, this gives you the most diagnostic view of the pelvic rami. And you can see that here. This is what the outlet view looks like. Okay, so basically increasing superimposition for structures above that. The sacrum is completely obscured. The coccyx is completely obscured. But you got a great evaluation of both rami of the pubic bone and then the ischial rami and ischial tuberosity. Optorabor foramen should be open as wide as you've ever seen them if you do this correctly. Okay. Centering point is low, right? So you're not necessarily going to see the iliac crests and all of the ilium. The top of your light field is probably going to end right around the ASIS. Okay. They do recommend a 14 by 17 field, but this suspiciously looks like a 10 by 12 crosswise field, if you ask me. Okay. And they're showing this with, so this doesn't match up to the patient that we have up here. The patient is a female patient. This is a male radiograph because they have a contact shield on the male gonads at the bottom of this radiograph here, this labeled radiograph. This labeled radiograph would be a good one for a quiz, so be mindful of that. Okay, so pubic symphysis, superior pubic ramus, inferior pubic ramus, ischial ramus. Can't really make out the tuberosity. That's more it's like self-superimposed over the ischial ramus. All of the acetabulum is pertinent anatomy, but not necessarily the femoral necks. You can see we've clipped the femoral necks off. If you actually do a 14 by 17 field, you might get the femoral necks and the trochanters and the iliac crest included. But like I say, I suspect this is collimated down to like a 10 by 12 from what it looks like to me. Okay. And again, structure shown. We don't foreshorten, right? Because those are canted. Those are not in a true coronal plane, right? They're kind of in an oblique plane from anterior to posterior. And so putting this tube angle, it kind of straightens them out and aligns them. So we're intersecting the rami, in particular the inferior rami, at a true perpendicular. Okay. So no, they look distorted, but because that's where we're used to seeing them foreshortened on an AP pelvis. Okay. So evaluation criteria, I decided to include this here because we're really not going to see the inlet-outlet pelvis series for routine x-rays. They just don't do them anymore. They're only useful in surgery for surgical repair of a fractured pelvis. So what are you going to see? How do you evaluate? How do you know you got a good Taylor method? Pubic symphysis is superimposed in the lower half of the sacrum. That's the first thing. Obturator foramen appear, they're not magnified, but they appear as large as if you've ever seen them. Let me get that, hang on. So yeah, sorry, interrupted again. Pubic bones superimposed over sacrum coccyx. Pubic bones and ischial bones magnified and not foreshortened. You shouldn't see anything overlapping the entire ischial ramus, nothing overlapping the entire inferior ramus. Slight overlap of the SI joint with the superior ramus. Okay. Both hip joints, okay, and this is a proper 14 by 17 exposure rather than the previous one, which I told you looked suspiciously like a 10 by 12. Okay. And it turns out they did get the top of the iliac crest on there. Yeah, you can really see the bowl shape of the pelvis on the Taylor method, the outlet method of the pelvis. Okay. All right, so moving on to our next, the Bridgman method is basically the other oblique projection, so other axial oblique projection of the pelvis. This one features, regardless of whether they're male or female biologically, a 40-degree caudal angle and that enters at the level of the intersection of the ASIS and the mid-sagittal plane. So both ASIS draw a transverse plane from the left to the right ASIS, and as that intersects the mid-sagittal plane, that's where you're directing your central ray. Okay. Again, you want the pelvis in a true AP supine type alignment, so no rotation, no obliquity. Don't let them favor one side or the other. Says image receptor centered to the level of the greater trochanters. So remember, with your tube angle, the anatomy is going to be thrown, the image is going to be thrown toward the feet of the patient. So you're not going to line up the Bucky tray with the top of the iliac crest anymore. You're going to line it up with the X-ray tube and the central ray. Okay. Okay, so shift the Bucky tray downward. They don't even have it lined up. That where that cassette is, that's not going to catch that X-ray. Y'all see that, right? Okay. All right, 14 by 17 inches again. Okay. And this is the radiograph you get. You're standing the sacrum up on its edge and getting it out of the way maximally. So you can see, basically you're looking at the pelvic opening, okay? What we call the true pelvis, all right? The pelvic ring, the pelvic inlet. That's what so you should see the greater sciatic notch bilaterally. You should see the ischial spines. Bilaterally, they should be symmetric. You should see both acetabulums, and you should see lesser sciatic notch into iliopubic column into superior ramus. The superior ramus and the inferior ramus are superimposed with each other. The pubic symphysis should be at the very bottom center of your radiograph. Okay. Let's see, superimposed lateral 2/3 of pubic and ischial bones, right? So the rami should be mostly superimposed with each other. Pubic and ischial spines symmetric. In particular, those ischial spines, you can see those pointing at the sacrum from each side, right there. They look like they're pointing straight at the coccyx. Okay. And again, the whole point of the inlet view is to measure the pelvic inlet, the true pelvis. That's all we got for the new hip and pelvis procedures, positions lecture. All right. Come in just under an hour and a half. That's not bad. All right. I will download this as an MP4 video, replace the one on YouTube, and send you a new link to Schoology. Y'all take care.